F. Okay. Okay. So I promised Santosh that I would show everyone about the Sydney ASM coming up soon. Okay. So I'm going to just reduce all the pictures. Okay. So as I said, I mean, I don't know how interesting this is to others, but for me and for our unit specifically, we wanted to make sure that we had some evidence behind change of our protocol, and we knew that there was a good animal data, um, but not a lot of data in humans. Maybe because I mean, the answer is so obvious, but we still wanted to have a look and have a look at the ANZDATA in Australia. So I will just go through the history behind it. The type of data that we collected, the analysis, and the results. So don't need to go through the whole history of organ preservation, but as you know, after the development of the urocolon solution in 1969, several very important and regularly used organ preservation solutions were developed. UW being one of the most commonly used solution in the world. Um, the James Southard and Balzer solution, also known as University of Wisconsin solution, the development of that was based on the liver, pancreas, and kidneys, and they really focused on the pancreas cold storage solution, and the primary focus was about the longevity, the viability, and the edema to do with the pancreas. So all of these ingredients were thought to be very essential in its development. Of course, the principles of organ preservation solution is shared across different types. So it's all about reducing cellular mitochondrial swelling, lessen intracellular acidosis, diminish production of reactive oxygen species, and provide substrates for metabolism with energy precursors. Now, when you look at large, country like France, where many units will use different types of preservation solution for organ procurement, um, you can see that, within one country, they're using 5 different types of solutions. And, there's a good analysis of almost 8,000 patients across 5-year period. And they found that between the IGL-1, UW, the Scott, Celsia, and HDK, no real substantial difference was identified with graft failure rate and creatinine at 1 year. But they did see that the delayed graft function was lower with IGL-1. As previously mentioned, all of these solutions will have similar principles and properties, except UW solution, because it is primarily focusing on pancreas preservation. They advocated for the use of insulin, the antibiotics, and dexamethasone, but the other solutions don't have those as part of the ingredient. I mean, there are theoretical advantages to the additives. So insulin, it stimulates production of ATP by glycolysis, prevents apoptosis, dampen inflammatory pathways, and reduce ischemic injury. And dexamethasone, of course, is a very powerful anti-inflammatory medication. It may reduce rejection, may reduce delayed graft function, and reduce ischemic injury. But of course, these are theories behind its use in the UW solution. Now, a large group from Nova Scotia in Canada went into the trouble of performing 280 orthotopic rat liver transplants. And they removed one ingredient of UW solution at a time and looked at the survival of the graft over a week. And the bar J is the one with UW minus insulin, and it actually has the highest level of graft survival. Similar sort of study 20 years ago, they performed 25, they procured 25 rat liver, after utilizing UW solution for organ preservation with and without insulin. And they saw that in a fresh frozen liver after the procurement, and at 6 hours after the procurement, they saw that the ATP, energy charge, and adenosine nucleotides were all reduced in the insulin group. And when they performed the liver transplants in 20 further rat with and without insulin, they could again see that from the liver biopsy that after the transplantation, the ATP, energy charge, and adenosine nucleotides were also reduced in the graft. In the kidneys, Monash University did a very similar study in 1990. They performed the rat kidney transplantation after removing some of the substrates from the UW solution. So group 4 is a group without insulin, and the black bar is the control. And between day 7, 14, 21, and 28, no huge difference compared to the control. And dexamethasone group also no huge difference to the control. So specifically for kidneys, it was concluded by the researchers that the insulin and dexamethasone may not make any difference for the kidneys when they are procured with or without insulin and dexamethasone in UW solution. So UW solution is the most commonly used, if not universal, across Australia for abdominal organs procurement and storage, and it is used after the initial cold flush. With the assistance from the members of the TSANZ and donor surgeons and donor coordinator committee, we were able to obtain 10-year protocols for the donation process. And it looked like about half the states across Australia had either stopped or planned to stop using insulin and dexamethasone in the UW solution. And this is certainly the trend across the world as well. In living donors, it looked like most states had already stopped adding additives in UW solution. So this created an opportunity for comparison of results by obtaining anonymized data from ANZDATA registry without formally completing a randomized controlled trial. So we obtained local ethics. We asked for data between 2014 and 2023, and all adult kidney recipient data was analyzed. We excluded en-bloc kidneys, dual kidneys, and simultaneous multi-organ transplants. We only looked at the deceased donors. And ANZDATA was very specific in ensuring that no data was identifiable. So they divided the data into group A and B, group A being centers where they used the additives in the UW solution, and B being they've stopped using the additives. And it was randomized so that there was no way of telling where the data came from. Using the data, we used RStudio, SPSS, and GraphPad Prism to look at delay graft function, allograft failure, and time to rejection. So there was about 7,000 patient data that we were able to analyze, and donor characteristics and recipient characteristics are there. And unsurprisingly, the donors are mostly in the late 40s, KDPI about 52, DCD for about 30%, and the recipients around 50, many of them extended criteria. And the median data is approximately 5 years out of 10 years. The delayed graft function, when we compare the two groups, as expected, no statistical significance in the difference. The statistical significance was demonstrated for certain factors such as total cold ischemic time, HLA mismatch, being females, obese, donor BMI, DCD, extended criteria donor, all the things that we would expect it to be clinically, statistically significant, but delayed graft function based on additives in solution was insignificant. The time to first rejection, again, OR or odds ratio 0.98, no statistical difference. and graft loss over 10 years, no statistical significance. Again, donor age, DCD, extended criteria, all expected contributor towards graft loss. So, of course, this is a retrospective analysis of a nationwide registry, which has its own fault as a part of the registry system. It's an opt-out system, and the data is dependent on the managers and the database custodians who collect and input the data. And there are certainly nuanced variations in our practice. I mean, we have state-based wait lists, we have slightly different perioperative management techniques. So there are slightly different surgical techniques, different surgical staff. So, of course, there are these nuanced variations, but we were not looking at these specifically, but looking at two groups broadly. So the conclusion is that as far as we are aware, this is probably one of the more robust clinical assessment of kidney recipient outcomes based on the use of additives in UW solution. The insulin and dexamethasone use does vary across Australia and even within the same unit, whether it be for deceased donors and living donors. And many countries across the world have stopped using the additives. Using the Australia-wide registry-based study, we found that the additives made no difference to delay graft function, time to first rejection and graft loss. The other advantage is that, I mean, the immediate cost saving to each case is maybe about $50. But a lot of times we do prepare the UW solutions with additives. And if the DCD cases do not progress, or if we discard the UW bags, it actually saves a lot of money. So I think there is immediate savings to be had here. And not only that, we may be able to unify practice a little bit closer. So yeah, this couldn't be done without the help of so many people from our department, the Donate Life, the Donor Surgeons and Donor Coordinators Committee, the TSANZ, and of course, ANZDATA custodians. So I'll be very happy to take questions.
Hi, Handu.
Hi, Henry.
Yeah, no, I feel I need to ask you a question because there's an
Yeah.
awful lot of work and it would be very offensive to not be asked a question. I mean, first of all, congratulations for getting the data. Just, I mean, someone texted me, so I wasn't sure. You maybe clarify, but the change from additives to no additives, were you clear on the exact date, or was there some probably time period where you perhaps had an admixture of additives that you classified as, no additives?
Yeah, that's exactly right. I think many units would have gone through the learning curves and discussions and research into the in changing the protocols, and we had an idea from the Donate Life written protocols that changes had happened at a certain year, but no, we didn't have specific dates. So we had to rely on the data from the Donate Life. But it would have been nice to get a
Okay.
specific.
And my other question, I guess, yeah, it would have been. My other question really relates to time points because we've been collecting for, I think, many years now, the time from, I guess, aortic perfusion to time organ on ice, on the back table,
Yes,
which has been proven by several jurisdictions around the world that time influences delayed graft function and actually kidney long-term graft survival. Did you look at that in this, or is that a separate presentation stroke paper? Because I think it's more trying to educate us all about, I guess, the need for some speed rather than just leaving the poor kidney as the poor cousin just sitting in the abdomen for 2 hours, which is definitely something that happens.
absolutely.
Everyone seems to focus on the liver and forgets those poor little kidneys.
Yeah, I think that's completely valid questions, and I completely agree with you, Henry. So we have asked for our own data to be released from the EDR custodians. So I have an idea within our unit what the average is, what the median is, and who the outliers are and what happened. But apparently, the getting that data from ANZDATA is not possible. It's not collected. They do collect the data on the total ischemic time, but not the nuanced specific surgical times. But EDR actually has all that data. So I was informed that to get that data, I will need to get a local ethics clearance, then have the ethics approved by individual hospitals who's going to be involved and get everyone's permission. And it just seemed like too much of an it just seemed like too much. So I haven't gone that far, but
I think,
yeah.
yeah. Could I make a suggestion that maybe just a small number of units, because we similarly collect that data, we could just, with 2 or 3 units, get a reasonable number, couldn't we, over a number of years?
Yeah,
And
yeah.
then maybe we'd be able to answer the question. I mean, it won't be, I agree, it won't be full national data or binational data, but at least it's something. I mean, I think, your unit alone has, what, 200 kidneys a year. So I think it would be great to look at a reasonable number rather than just, I don't think we're going to change the world by looking at Westmead's numbers. We don't do enough kidneys, do you see what I mean? But it'd be great to combine the numbers.
Yes.
It's perhaps a little project. I see Amar Hamid's online, but I think and Peter as well. But that would be lovely to do something like that, just to get enough numbers, because we're very difficult to compete with North America. Our total numbers are so small.
Yes.
Um, anyway, just a future project.
Yeah, that would be a great project for some of the PFAT joining us.
I mean, I seem to remember, just as another comment, I don't know if anyone's got any other questions, but Amaroda, he did a review of pancreas retrieval, I remember, and there wasn't actually a statistically significant difference in pancreas outcome in terms of graft survival or pancreatitis. I think there was a difference in the peak amylase lipase rise, but it didn't impact on, the actual graft thrombosis or graft survival of the pancreas.
Yeah,
But that
that's
was that
true.
right? Was that my memory correct? I don't know.
Yeah,
I'm debating, but
your memory is definitely correct. I did a
yeah.
liver one as well, and I think it similarly wasn't different. But there are some large registry analyses saying that it is much better for liver and pancreas. I think, but when you combine some of the papers, it wasn't sort of borne out. I think having just come back from Edinburgh, they certainly preferred UW there as well. They had a period where they were using HTK because they were forced to because of contamination, and then sort of they were all sort of thankful when we went back to UW. They certainly seem to think it impacted their outcomes.
Does anyone else have any other questions? I feel like I'm monopolizing Handu, but can I ask another question?
Oh, yes, please.
I mean, I remember being taught years and years ago that it was actually the fluid that you place the organ in was more relevant and impactful in terms of subsequent outcomes than the actual perfusion fluid. But presumably, though, it's one and the same, isn't it? If you perfuse with UW, you're going to stick the kidney in UW.
Mm.
Um, I guess it's hard to separate that out, isn't it? So is it just dogma, historical dogma, or maybe it doesn't matter at all? UW is very expensive, but can you answer that one, or is that again unanswerable?
I would have thought the practice was that all the UW is prepared the same way, and for organ flush as well as the storage, it would have been similar in most of the units. But I have to say I don't have an answer to that question. Is that do you remember, Henry, before Westmead stopped using insulin dexamethasone, that you used to use that in the storage solution as well?
Well, no, it was really just a thought about, how we are obsessed with the use of UW for particularly the liver and pancreas. But,
Mm.
could we save ourselves an awful lot of money and just perfuse with cold saline? and then just transported in UW, because there's this belief, as I said, this is what I was told, but again, a lot of what I'm taught is completely without any proven evidence that, because UW is way more expensive than cold saline.
Yeah,
I guess no one's going to be prepared to do that trial. But
Maybe
it is
animal studies
interesting how
first.
we are very slow to change. Yeah. Do you know any evidence, Summer, from your knowledge of perfuse aids?
Oh, I don't think so, but I think, yep, as you say, people would be very hesitant to ever check that, because if you're just storing it in the fluid, presumably it's not going to penetrate the whole vasculature, and it will just be touching the surface. That's sort of like the floating the pancreas on UW type trials for islets, I think. Yeah, but it won't penetrate too much, so I think, yeah, you'd be hard pressed to find people wanting to do that.
Yeah,
I
I
know,
do remember
but
seeing
just think of the
crazy.
cost saving.
Yeah.
Yeah, I do remember seeing this crazy article where they had the liver grafts in UW solution, but perfused the vessels with oxygen, um, and that they had to poke the surface of the liver to let some of the gas out. But they seem to think that after transplanting those liver in dogs, it worked okay. Um, I don't know how you would flush all the gas out beforehand, but you know, that was the early days of oxygenation of the organs.
Yeah, there's a lot of wacky stuff out there, isn't there? The,
Any evidence about the volume of UW that's required for, a standard multi-organ donor, Andu? Because I must admit, I usually find the effluents, got as pink as I can be bothered, and then I just, pull the cannula out. But I know that my RPA colleagues, want me to use 5 liters, and I've just got too bored by 1.5 liters, and then we take it out,
Mm.
put another liter on the back table. But is there a critical volume, or again, that's unproven?
Yeah, I think that's also very center specific as well. I mean, when I looked at our unit's data for multi-organ, including the packaging, we are between 4 and 6 liters. So I think our practice might be fairly similar.
Yeah, we use a 4 liter pre-flush if it's just liver kidneys, and then a 2 liter pre-flush if it's pancreas as well.
Yes.
But therefore they don't get so much UW. Probably I would say 1.5 liters
Right.
before, because it's still quite a lot of volume. Say someone who's 70 or less kilos.
Mm.
Um, yeah, I don't know, but everyone does something slightly different. It doesn't appear to make a significant difference, does it? But it is interesting.
It is. So much data points, and it will be, I wonder how accurate the EDR is with all the solution that we use and time points um but I mean, yeah, the last time I checked the EDR data, there is a lot of data in it. But one of the things that we emphasize with our new fellows are to not forget the kidneys, because sometimes you're worried about the liver and you're doing some back table, and we've seen organs left in the body for up to 40 minutes when things have gone disastrous with liver. So, you know, when one organ is not doing very well, we still have to think about the others.
And in Queensland, I heard a rumor that you take them out on block. Is that your standard retrieval, or is there a bit of a difference in Queensland for kidneys?
Yeah, we in the last couple of years we tried to um, enforce, on block removal, just to minimize the risk of us having to reconstruct accessory vessels. And I think it's been successful for us. I mean, we just by uh, uh, opening up the aorta, you get a very clear idea about where there may be accessory vessels and whether you can, use the aortic patch to reconstruct, or certainly as a urologist, I find it easier if I don't have to do much of a vascular surgery.
Hmm.
I think it's still a
Uh,
little bit dependent on surgeons, Prof. Pless.
right.
I still
Yeah.
split it.
Oh, yeah. And I mean, I think, I guess if that was your routine, it's great for pediatric on blocks because you're just doing what you do all the time.
Yeah.
But then pediatric on blocks are so tiny, it's kind of a little bit easier anyway. I know I wondered whether there was a difference in outcome. I mean, I always retrieve the right kidney first, and then the left kidney comes out last, right? So that probably isn't a huge difference in time, but it is a difference in time. And funnily enough, we know that right kidneys have a poorer outcome than left kidneys, both, cadaveric and live donors. So that doesn't figure, does it, with that
Mm.
technique? So maybe that difference in time doesn't matter. Yeah. It's another unanswerable question as to what is the cause of right-sided graft loss. Is it because the artery is too long? My feeling is the artery is too long and gets kinked rather than the veins being short. Or maybe the vein is too long because everyone uses the vena cava.
Yeah.
That would be a good little survey, see whether of the whole world's, or even just Australia, New Zealand, just to look at what proportion of surgeons use the cava routinely, because I definitely don't. I do it. I use it, literally less than that time in my life, but I'll do it if I have to, but not my routine. But some people use it totally routinely.
Yeah. I have to say
That
that's
that would
been
be
routine.
interesting. And,
Yeah. And the
um,
discrepancy in vessel length, how do you manage, Henry? Because if you use the right renal vein, the artery awfully looks longer.
well, I'm pretty lazy. I tend to leave the patch and try and go as high up on the common iliac as possible.
Uh-huh.
Do you know what I mean? But sometimes you just can't get there.
Mm.
You know what it's like. It's sort of, you're a hugely obese person, you just can't access it, or it's diseased.
Yes.
Um, and then I worry if the vessel's kinked. I'm pretty lazy. Rulan I can see has got his hand up. He's a much better surgeon than me, that's for sure. Rulan?
No, I don't know about that, Henry. There's more a comment. I mean, we started using hypothermic oxygenated machine perfusion, and with that machine, you have to use a proprietary UW. It's UW machine perfusion.
Mhm.
And I've often wondered like why we do that. And I guess in the future it'd be interesting to see if that UW really makes a difference, or if it is just the oxygenated perfusion. And you've been using perfusion quite a lot for much longer than we have. And I wonder if you've had that thought or any similar sort of thoughts related to it.
Yeah. Oh, thanks for the question, Roland. So there are in Australia, as far as I'm aware, there are two or three hypothermic perfusion fluids, and when you look at the ingredients, they're all exactly the same. It's a variation of UW solution, without the viscosity. Um, so, we use KPS1 because, I mean, company kind of advocates for it. It's expensive. We don't have an alternative to buy. So that's what we've been doing and using, well, we're hoping to use oxygen much more regularly for extended criteria donors and DCD donors. Um, but yeah, that's where we're at. But if you know of a company that sells again the same stuff much cheaper, love to have a look at it.
Yeah, I agree. I mean, the costs just add up, don't they?
Definitely. Oh, well, if there are no more questions, I'd like to thank everyone for coming. It's I know it's Monday 6:30. It's dinner time, family time, so I won't take any more of your time. But just a quick reminder, Santosh asked me to remind everyone that the transplant the RACS ASM transplant session is on 6th of May, and the dinner is on 4th of May. So that's Sunday night dinner, and the session is on Tuesday. So hopefully everyone will be there. I guess I'll
Look
Thanks,
forward to it. It'll be good. Thank you very much. That was a very interesting talk, and we should I think keep in contact about the I guess what are we going to call it? We call it the donor in situ ischemic time, or DISIT. That's the term we've sort of coined. So the DISIT time, we've got quite a lot of data on now in terms of outcomes. But again, it's just our own recipients. Yeah.
Fantastic.
Anyway,
Okay,
take care.
that sounds like a great plan. Thank you so much.
Bye.
Have a
Thank
good
you.
night.
Thank you, Andu.
Thank you.
Bye.
Bye.
Thanks.